Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind Podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. My guest this episode is also Dan Howes. Dr. Howes is a professor in the departments of emergency medicine and critical care medicine at Queen's University in Kingston, Ontario. He spent the past 25 years with a clinical and academic focus in resuscitation medicine, particularly crisis leadership, decision making, and the challenges of teaching those skills to residents, which is an incredible bio and like directly applicable to everything that we do here in the Emergency Mind podcast and project in general. I was really fortunate enough to get a chance to sit down and talk deeply with Dan at a recent resuscitation conference in Kingston. And I am delighted to have you back on the show here and dig into it perhaps more publicly than we did last time. So, Dan, thank you for coming on the show.
Fantastic. Thanks for having me.
Absolutely. Can we start? Can you give folks some context about the place that you're working at and the systems that you all have designed? And my hope is that in doing that, that can lead us a little bit into the history of how you all put that together, because it's a pretty unique and pretty amazing place that you all work at.
Sure. The resuscitation program where we work is one that allows us to bundle together some of the different silos of resuscitation that are usually in a hospital. And so what we do is we have a single individual or group of individuals, once you count the learners, on the cardiac arrest team, the critical care response team, and the hospital's trauma team. Is where the regional trauma center for our area. And that, I think, has been a really exciting way to be able to try to craft the subspecialty of resuscitation medicine and allow a group of people who really are drawn to and enjoy the type of work that is resuscitation medicine and to apply it in different ways all at the same time, instead of having it be just this rare, sporadic part of a bunch of different people's jobs.
Okay. So let's wrap some context around that even more. You said, I don't think I've ever heard this said this way, but I love it. The silos of resuscitation. What does that mean? What are the silos of resuscitation?
I guess what I mean by that is just that there are lots of specialties where the resuscitation of a patient is part of their work. Whether you're an emerg doc, an anesthetist, you are a hospitalist, you do internal medicine, all of these people have things that go wrong, or they are particularly serving a population of patients who require resuscitation. And for the most part, I think those groups of people communicate reasonably well with each other, and we tend to talk about lessons learned and that sort of thing, but certainly not perfectly. But also with that distribution of what are hopefully a relatively small number of events, you have a large number of people who are doing what's a pretty important type of medicine rarely. And instead, the hope or intention is to see if there's a way to allow a smaller group of people to do it more often and to develop some true expertise.
So that's really interesting, because when you look at medicine as a system, right, there are certain subsets of medicine that do a thing. So nephrology does kidneys. Cardiology does hearts. And obviously, the human is a complex system with interconnecting parts. So you can't just do the kidney. You have to also think about how the kidney intersects with the rest of the human. But you have some slices of medicine that are thing focused and some slices that are time focused. So primary care does lots of things, but it does it slowly and over long periods of time. Emergency medicine does anything, and it does it quickly for the first part. Critical care medicine does, you're in a bad place and we're going to try to get you to a better place. I'm not a critical care doctor, but I assume that's close enough to,
in summary, though,
yeah, to what we do. But it's interesting that there's not in most places a resuscitation concept like what you're describing, right? We see it fitting into those little pieces. It's a Venn diagram of everybody taking their own slice. And what we know from that, just if we look at it from a systems point of view, is that there are strengths and weaknesses to that approach, right? The strength of that approach, or one of them at least, is robustness and resilience. So lots of people in a hospital can do resuscitation. They might not do it the same way, but they could do it if they were called upon to do it. So it's a rapidly responding system like that. One of the weaknesses, of course, is that not everybody who does that might be as skilled as they could be. And you're looking at low numbers of things where it makes it a lot harder to generate expertise at it. So it's really interesting that you all are taking a bit of a different approach to it, which is to create almost this idea of a resuscitationalist. I don't know that I see a lot of folks doing that.
The one other analogous type of practice in medicine, I think, and this isn't something that is so much in Canada, I think it's more in the US, is the acute care surgeon,
Mm.
the one who, and often it's combined also with trauma resuscitation, but they do the emergent surgeries. And I think there's a fair bit of variety in how that happens. But it is, I think, quite analogous in that, from what I understand, there's a certain mindset of decision making and skill set that sort of goes along with that type of surgery. And for us, really, it seemed to make a little more sense to put that more on a medicine side
Mm.
of things. I think the other thing to remember is that going back to the idea that some of the silos, people like doing resuscitations, or, for
Right.
example, emergency medicine. There are a lot of people who got into emergency medicine because it is a type of work that they enjoy. There are a lot of people who are required by their job currently to do resuscitations because they get into those circumstances who really do not like it. It is stressful for them, it's uncomfortable, and they're very happy to give those experiences away. And I particularly think, I mean, the practice of medicine is hard enough without also having to be uncomfortable with what you're doing. And so there definitely should be a resource or an opportunity for people who do not like those kinds of situations to be able to get themselves out of them.
Yeah, absolutely. I think we often see that the challenge to that, of course, is that in a lot of places in a hospital, the people who are first responding to a crisis, who are recognizing a phase shift in a patient between stable and unstable, not necessarily the ones who signed up to work on resuscitation and high impact events, right? Often we see this, you can imagine a person admitted to a floor bed, a standard medical bed, for some problem that everybody expects will take several days to resolve or whatever it is. And the general trajectory of those patients is up and out, which is that they do better and they leave the hospital. But often that's where something changes, a crisis happens, and the team that responds to that event, the first one in the door tends to be the person who wants to work on a stable, steady floor, not the person who wants to work in acute care surgery or critical care medicine or emergency medicine. So there's a balance in there between designing a system that puts people in the roles they want and also designing a system that's resilient to whoever's in first can help make a difference to it.
Absolutely. Yeah. And you're right. There are pluses and minuses either way. And I suppose in any one particular situation, it really depends on how often these kinds of events are happening,
Mm.
whether the trade-off of losing the resilience in the greater team, all hospital staff, versus the advantages of having some selected expertise and the opportunity to really practice and get good at something.
So the group that y'all are building, and I don't think we've said this word yet, but this is the race doctor, right? Is what we're calling it. Pace doctor. Should
Yeah, so in our hospital, we call our critical care response team physician, yeah, the race team physician.
Great. All right. Thought I got
And
that.
this is not unique to our hospital at all. This is something that we're part of a provincial program. There are a number of hospitals in our province that have these teams,
Awesome.
and they consist of a physician, a respiratory therapist, and a nurse. And I think one of the, sort of to get to your point of the sort of recognizing sick, one of the key things that makes these teams work is their openness to activation. The race team can be activated by anybody. So it can be activated by a nurse, a porter, someone who's delivering food, by an attending physician. We have had patients activate for themselves because they saw the poster. We even had one race doc have to activate the team on himself when he had a medical emergency in a stairwell.
Oh
But
no. Yeah.
anybody can activate the team. And you make the bar low. And I think the key to it too, it's not just making the bar low by saying the bar is low. The behavior has to match. We work really hard. It's not perfect, but really hard, no matter what the reason why the team was activated, to welcome that opportunity to come by and visit the patient to see if we can help. And it doesn't matter if it seems like a more trivial issue to the team. It really doesn't matter. If the person was concerned enough to call, we're concerned enough to show
Mm.
up and to offer to give them a hand.
Hmm.
And that, I think, is the key to these teams really working.
So there's a couple components that we've listed about that idea of what are the keys to make something like this work, right? So one of them is this openness to activation. Another one you mentioned is having the right operational tempo, having enough of these events put together that a team can respond and can get better to it. And so you mentioned a couple of ways that this team would respond: the cardiac arrest team, the critical care response team, the trauma team, some of these big pillars of it. What else goes into having a team like this work? And I would imagine there'd be things that are around training the team. I'd imagine there'd be things around training the system of how to use the team. And then I imagine there'd be some sort of a feedback loop where everybody learns from what happened. But I think I'm editorializing a little bit based on our prior conversation. So what else goes into building that sort of a thing?
No, I think you're right. I guess the one thing to clarify is that the teams in our center right now, anyway, the teams, those are three separate activation pathways, and in some ways are often separate teams. So the cardiac arrest team's activation is fairly straightforward, and the folks who respond to that are similar to those who respond to the race team. We have more learners on our cardiac arrest team than
Gotcha.
we do on our race team. The trauma team is a somewhat different team, but same leading physician. And I will say there are most of the docs who do this work right now do these as a bundle, but we still have some physicians who, for example, only do trauma team. And so
Gotcha.
on that day, someone will be just covering the race team. But around the teams working and the team effectiveness, it's this constant balance of trying to find and maintain expertise. So people who are very experienced, and our responsibilities as educators. So having people on the team who are learners and who are new. And certainly we have both. And we're, I think, probably like every other teaching hospital, always struggling just a little bit to find what the right balance is between giving someone autonomy and a little bit of rope, but still prioritizing care of the patient above everything else.
And Dan, how did you get to this? Right? Like, how does this look different than how you trained? And where along the line of that arc were you starting to envision something like this?
I think for me, there were a few different things that happened around the same time. I
Mhm.
went into emergency medicine and did critical care because I really enjoy resuscitation medicine. I love the pace. I love the critical nature of it. I like the feeling that the work that I'm doing is really important. And I really enjoyed that. And when I was training in emergency medicine, we did a fair bit of resuscitation on any given shift. But for me, emergency medicine changed a lot over the first 10 years of my practice, in that the number of patients coming to emergency departments blossomed, and the work that we were doing that still included resuscitation medicine was much more broad.
Mhm.
And there was a much greater variety of different patients and presentations. And it's all good work and it's all very valid work. A lot of it I found, though, that I didn't enjoy as much. And so I was looking for a way to be able to consolidate my resuscitation experience and my resuscitation practice. And then the other was just at the same time, there were some political issues around trying to get physicians paid, and
Mm.
there wasn't the amount of funding that we might have hoped at that time for our trauma team. And so it was very difficult to schedule people. And
Mm.
so the opportunity to try to start putting some of these teams, amalgamating them, bringing them together was a great opportunity, both from a practical point of view, but just also from a desirability of practice point of view.
And then where did the resuscitation fellowship come from or start from, or how does that intersect with all of this?
That all started right around the same time, in that this obviously wasn't just me. This is a group of people who shared my joy for resuscitation medicine. There are some folks who like it and some don't.
Yeah.
And there were a bunch of people who really liked the idea of doing this. And we recognized that fairly quickly, the more that you're doing this, the more you want to learn yourself, but also the more people want to learn the stuff that you're learning. And that was really what we found, that there was enough to resuscitation medicine that it deserved additional training. There was content that wasn't present in even training programs like emergency medicine or critical care,
Mhm.
because there was enough depth. And to tell you the truth, I think the big change in resuscitation medicine, the medicine itself is not the hugely complicated part. I think the real blossom was the kind of work that you do, and that's the cognitive side of
Mm.
resuscitation medicine. And as we started to realize that is a huge part of resuscitation medicine, that area is broad and there's a lot to learn. And so it gave this sort of great additional content for a resuscitation fellowship.
And obviously, I imagine we're fairly philosophically aligned on this, but why do you think that is? Like, why is the cognitive aspect of it so much of our ability to perform resuscitation medicine? Is it just the stress and pressure? Is it just the teamwork? Like, I think I have some thoughts on this, but I'm really curious your take on it.
So do you mean what is it that makes it attractive, or what is it that makes so much content?
Yes. And I love that we're going on this theme of the joy of resuscitation, because I think that there truly is a joy in it that you are drawn to or not drawn to. And I very much agree. But what you said was really interesting, which is that it's not necessarily that the blossoming of medicine has changed, although it has. Right now we have ECMO, we have all these other things that we didn't used to have. Ultrasound so much more key in our what we're doing, and I'm sure that this conversation that we're having is rapidly going to become obsolete when AI is more involved in helping us understand a lot of this stuff. But especially amplifying weak signals and things like this. But it's not so much the availability of tools as it is the focus on how individuals and teams operate in those spaces. And why is that? Like these tools we have are amazing. So why are we still focused on the communication and thinking and mental model aspects of it?
For me, I think one of the big reasons for being focused on it comes from trying to teach it. Because, and I don't know, tell me if this is similar to your experience, but there are lots of folks who come to us and want to learn resuscitation medicine, and they do very well. And we're pretty lucky in medicine in general. It's not usually a very hard group of people to teach. But there are some folks who really struggle. And I would say early on in the fellowship, everybody who we got were people who were really drawn to resuscitation medicine. But we started getting requests and asks to also help people who, because of their job title, were required to do resuscitations, but were really struggling. These are the folks who freeze or who have other responses to a stressful situation that makes it very difficult for them to perform. And for lack of a better term, that's really interesting. And it may bring up, I feel a little embarrassed saying that I enjoy resuscitation medicine, because particularly to people who don't practice it a lot, that may seem a little on the dark side. And enjoy is probably the wrong word. I don't know if this is the same for you, but in really stressful situations, I find I go into a state of flow,
Yeah.
right? I become very comfortable. Things almost feel like they slow down, and it's not a happy experience, but it is, for whatever reason, it is a positive experience to be in that state. And it's the practice of doing something very difficult and knowing that it is going the way it's supposed to. And there's something very rewarding about that. And to try to get people who instead experience that in a very different way, in a way that is very stressful and very negative, and help the help them change the way they think about it or approach it, so that they can come to it being a more positive experience. And I still don't know whether that's always possible or not, but there are certainly times that it's possible.
Dan, there's a lot in what you just said. Thank you for that. I think that's really important. I think if you look at the research on flow states, I think that would match a lot of what you're saying. Both the idea that flow is not happiness per se, but I don't know that there's like a good English word for it, but it's like the joyful nature of chaos that you're in the middle of for it. And you realize the gravity of the situation as well as the potential of the situation at the same time. And there's this thought that it's a challenge, but it's a challenge that you feel like there is possibility in, right? Like you can do your best at this. All of that really matches what I understand from the flow space of things. And there is this tension in there, right? Because you don't want other humans to be sick or injured in the way that it
Absolutely.
is. But you do want, if that happens, for them to come to you, because you want to be the one and your team wants to be the one who wants to step forward into it. And I think that desire of, I don't wish this on people, but if it happens, let's go, is something that's very common among the broader space of folks probably listening to this podcast, whether they're in law enforcement or firefighting or anything else, right? Like, we're here to help things get better. And that requires an ability to step forward towards problem sets, even hard ones, even ones that we wish maybe weren't happening. So I think there's something really powerful in that thought that it's okay to have those feelings. It's okay to lean into those feelings. And it's also okay to realize, okay, so you're just going to have a slightly different stance in the spectrum of what it means to be human than you might otherwise, because you're going to occupy some space that most people aren't going to occupy. You're going to do some things that most people aren't going to do. And that there's a fullness of expression of being human in some sense by being in that space, to wax philosophical for a minute about it.
No, that's it exactly.
Yeah, I think that's really well said. So I'm curious. We've done a little bit of research in this space, and we're asking a lot of people this next question in the setting of various parts of the training pipeline. But do you think that performing under pressure is a character trait that you have or you don't, or a skill that you develop through training?
I think that there is a certain amount of each. I think, and certainly there's a certain amount of each at the point that I encounter people.
Mm.
So, and we start training people, they're usually in their mid to late 20s. And so they've had a lot of life experience. So it's hard to know how much is personality and how much is just based on their previous experiences. But I truly believe that everybody can be taken from where they are to somewhere farther along the spectrum. I think some people, whether it's personality or just where they happen to be, can be taken quite far and can really extend themselves, which is, as an educator, a really enjoyable experience. And it's fun to watch how amazing some of these learners can get. And they get to the point where they're certainly performing better than I am. It's just a really nice thing to watch.
Mm.
But it is also really rewarding to have someone who has been struggling with something move to a point where they develop some comfort and they
Mhm.
can and they perform better for their patients. And whether it's some of it just deliberate practice or whether it is helping them reframe the way they look at things to a certain degree, but to be able to bring them, farther along that continuum.
And these folks who come to your group and they're maybe struggling a little more with this kind of work, is that, are you seeing that as like a training scar? Hey, something happened and it created this resistance and it created this friction to it. There's some bad outcomes and some bad cycles that happen. Are you seeing it more a lack of familiarity and experience with something? Like, oh, they just need more cycles to polish it up? Or is it something totally different than that? Yeah, I guess let me ask that question better, because that was leading and false dichotomy and everything all rolled into one. When I think about folks that come in who are having challenges with resuscitation, with the individual skills and the team skills, or the team skills of resuscitation, like you said, sometimes it's not obvious where that comes from and why they arrive with that stuff in place. Some options I've seen are training scars, right? They went through experiences when they were very early in their development that left bad outcomes or bad tastes and or created bad habits, which now have to be reversed. Some of it is lack of experience, which is that they just haven't had time in that space in a safe and graduated pressure environment to develop their own feet underneath them. But I don't know that either of those two mental models fully, singly, or severally capture the space of what we're looking at for this. So, where do you think that stuff comes from? Like, why do people struggle with this kind of space to work in?
So I have two somewhat dichotomous thoughts. The first one I would say, I think every sort of resident in trouble, the struggling learner, should be approached very individually. They really need almost a diagnostic workup. And I
Mm.
think thinking of it diagnostically really is helpful because there are lots of different reasons why someone struggles. Having said that, for residents who are struggling, particularly with crisis situations, it often comes to or seems to be an issue around cognitive load. And I know this is something you and I have talked about a little bit, the sort of and I know you've had other people on the
Mhm.
podcast speaking about cognitive load.
Adam in
Uh,
particular, right? Yeah. Mhm.
yeah, and I think it's an area that without some purposeful coaching, is hard to work yourself through. Part of the reason why we're so lucky in medicine is most of our students go off and learn all the stuff they're supposed to learn by themselves anyway, and we take the credit for it. But things like this are very hard to bring yourself out of. You need an external voice and some external observations to help you move yourself out of the little spot that you're stuck in. But for some people, that really is all it is. It's just that little bit of
Mm.
being stuck. And I think you're right. Sometimes it is quite possible for that to be based on an early scar. So a really unfortunate circumstance that they may have been in earlier in their training.
What else would go into that diagnostic workup for you? Let's say let's just make a bit of a fake scenario here where you haven't worked with this person before, but you get a new resident. His name is Dan, because everybody on this podcast is named Dan at the moment. So
Absolutely.
exactly. So he's Dan, and he was coming to you from some other program. Is a transfer for reasons unknown. And all you know is, hey, this person struggled in the resuscitation space before, right? What is in that diagnostic workup where you're trying to sort through the why of that?
So it's funny you ask that because one of my great medical education mentors, an emerge doc here named Mike O'Connor, so he was a great medical educator. And we brainstormed for a little while and even went looking for a little bit of funding around the idea of creating a diagnostic center for residents in trouble. And so I'm going to give the answer that is mainly his ideas, not mine. So that's why I'm just laying it out there. But the idea that for the resident in educational trouble, that it really needs to start with, first of all, a barrage of psychometric testing to uncover any hidden learning disabilities or struggles, a deep dive into substance abuse, external stressors, those kinds of things, an evaluation of knowledge content. Is the knowledge just not there? Is this purely a content issue? And in my experience, it very rarely is that. And then if all those other things are there, a close examination, ideally in the real world, but probably more often in a simulator environment that looks at the application of the knowledge and why that might be failing to fall through.
So we're splitting here a little bit into knowledge factors. Do you know the thing? Application of knowledge. Do you know how to apply the knowledge under pressure? And then a third bucket, which I guess you could lump a bit grossly into extraneous cognitive load, right? Things that aren't directly related to your task at hand. Family stress, life stress, substance issues. Are you sleeping? Are you eating? Are you doing the work that it takes to be a human under pressure like this? Those are the three buckets. That am I missing one in there?
No, I think that's right. I must say I divide them up differently. Only then
Mm,
I separate the cognitive issues and the substance abuse issues and the
sure.
psychological stressors somewhat, because I think the approach to them is very different.
Fair.
Whereas when cognitive load, and I think that the concept of cognitive load is evolving a bit almost out of just the pure working memory stuff and more into executive function. And certainly there are lots of things that can tax your executive function. But that, if executive function has three main buckets, the sort of cognitive inhibition part, the sort of suppressing system one stuff that's going on, the actual working memory, and then the cognitive flexibility, the ability to be creative. And I find for most of the learners who are in trouble, and again, lumping them all together is probably not fair, but in
Sure.
this theoretical student named Dan, it would be quite possible that Dan's trouble actually is that he has no more executive reserve because everything is being used to
Mm,
suppress the emotional response to the event. And
sure.
that is using up everything. So he can't think. He certainly can't plan ahead, can't anticipate what's going to happen because everything is all about not running screaming from the room or hiding under the bed and trying to find ways of reframing the
Mm.
situation so that the emotional response isn't there as much.
It's super interesting. I when I put on my mission critical teams hat for a moment, one of the things we see in a lot of the other teams that aren't medicine is a much more coherent and organized selection and assessment process, right? So if you're going to join some team, you spend time testing under high stakes, high pressure scenarios to determine if you are the right makeup and have the right tool set and are the right fit for this team. And so a lot of this kind of question of what is their ability to learn and operate under pressure would be handled in a selection assessment phase. And then if you cleared that hurdle, then there'd still be, okay, we need to work on things with you and you're in the fold, but now let's build you up. Medicine's a little bit different like that. There's a gate selection, right, when it comes to emergency medicine, but then there's not necessarily a long-term selection period like this. And once you're through that gate, you're in the team. And our job is a lot more how do we elevate you and bring you up to speed and get you faster than us as soon as possible for it. It's just interesting to think about the different structures of those models because I don't know that this same conversation about this would happen in other spaces that weren't medicine that had more of a weed out selection approach to it. I don't know. There's a
Well,
question there, just thinking out loud about it.
yeah. And I guess what I'm find myself wondering is why, because I think it's fair to say our selection process, although we try to make it rigorous, it's not as robust, certainly as many other areas where there is selection. And one of the groups of people who I think we do a real disservice to are the people who find themselves wherever they are in medicine. But for example, emergency medicine. So they find themselves in emergency medicine residency, and because they thought it was something they were really going to enjoy, but they actually just really liked the idea of being an emergency physician. And maybe it's not as much the work that they enjoyed, but it was someone meaningful that they admired. So somebody, Dan, worked with you in the
Sure.
emergency department, really liked you, thought what you did is super cool, and so made that their goal without maybe realizing that actually a lot of parts of the job are quite hard and that the job overall isn't that great, or that their personality wasn't suited for it.
Right.
Maybe they hate making quick decisions with only limited information, and they're much more comfortable in a situation where they can entirely know it. And I
Right.
think in medicine, we don't do a great job of helping those people, I think as Disney puts it, find their happiness somewhere else. There is a place that will match them well. And but I guess what I wonder is why don't we do that?
Yeah, I think that there is a bit of a sense of, and I think this is probably an unfair assessment, but there's a bit of a sense of failure in that, right? If you go into a path in medicine and that turns out to not be your path, then somehow there's a judgment on that. There's a failure judgment. And that's as I get older in medicine, I believe that narrative less and less. I think that there are many, first off, medicine is broad and medicine needs a lot of things like the art and science and systems of keeping people healthy and alive, a lot of brilliant people working in a lot of different places on it. You need the person that loves making slow, very detail oriented decisions about how something gets put together, just as much as you need the person that makes fast 51% equals 100% decisions on the other end of it. And so I think it's a bit of a false tribalism that allows us to be like, my way is the best way. And if you can't do my way, then you're probably not worth your salt.
It occurred to me that somewhere there's an internal medicine podcast going on where they're trying to figure out what to do with the residents who will not stop and think and take their time and put together a good differential diagnosis. What do we do with those guys? Yeah, we need to be better at helping people get into
Yeah.
the areas that make them happy. Because it's a long job.
Yeah.
You got to be happy doing it.
That's so true. And if you're listening to this and you know what that podcast is, please connect us so that we can have a joint podcast and we can have this discussion. We had one hospitalist on the show so far, a colleague of mine from Mass General, when we were both at Mass General, neither of us are there anymore, Nkem Mbojigwe. Nkem is a brilliant doctor who works from the hospitalist point of view on this stuff. And we had a wonderful conversation debating the different mindsets and different things that it took in there. But it was almost more a conversation of like similarities than it was differences. We ended up talking about the rapid response team because it's a bridge between what the two of us do. But I think there's a real sense of like we should be having these conversations about, wow, what are these different groups really good at? What are we uniquely good at? And how do we share those different mental models to it? Actually, I've always been fascinated by folks like yourself who have trained in both emergency medicine and critical care, because in some sense, those are very different parts of that spectrum as well, right? One is a rapid response to stuff, and the other is a game of centimeters or even millimeters, where you're just very finely advancing something and accumulating marginal gains to it. Do you feel that? Do you feel that tension internally as you do this work? Or does it feel more like different pairs of lenses that you snap in place, or how does that work?
I don't find tension with it. I quite enjoy it. So I don't do emergency medicine shifts anymore. I just do the resuscitation
Hmm.
work and I do critical care. And I enjoy both of those worlds. And but I but it is also fair to say that there's a different mindset that you have while you're doing it.
Hmm.
Your question points out really well. I think that again, we're creating this false dichotomy, and that there's the quick thinkers and the more pondersome. We've all got the capability of
Sure.
doing both. And maybe part of what happens as you develop more experience is the ability to know when to use which mode and to not get tricked into trying to make quick decisions when there's no need to, and but also not being able to move into a position where you're comfortable with the decision despite not having all of the information and a certain degree of uncertainty, and just being able to accept that. Yeah. Like, the critical care medicine is very different from the resuscitation medicine, most of the time, or at least once the patient is established under your care, but also really rewarding, but for very different reasons.
All right. So I have three questions from this that we can pick any one that you like, and that'll probably be us heading towards the wrap up of this conversation, unfortunately. But all of that come out of this. So we're setting up these different ideas of ways of thinking and acknowledging that it's a little bit too splitting as opposed to lumping, that there's probably collaborations and connections between. But if I'm early in my career and I'm looking at this, how do I know ahead of time which of these things I'm good at? And from the other end of the career, you could ask that as if I'm evaluating a candidate or somebody who's coming up the pipeline, how do I figure out which one of these things they're probably good at? And then the second question is some version of how do we train at whatever the opposite of our best skill set is? Because we really need both to work. And then the third question is some version of how do we train people to swap back and forth flexibly and rapidly between them? So if you could just solve all those problems for me, that would be totally wonderful.
Yeah. And they're all really good questions. I think the sort of idea of I like the idea of helping people work on different mindsets and to be in different situations. I don't think there's a shortcut to it though.
Mhm.
I think that some of it just comes from experience. And I'm a little torn because I'm a big believer in going to your strengths. And I believe that you achieve greatness by elevating your strengths, not by focusing on your own weaknesses.
Sure.
But you find ways of using your strengths to act as umbrellas for your weaknesses, I think. And for someone who is a rapid decision maker or is comfortable with rapid decision making and comfortable with decisions in uncertainty, maybe part of it is just recognizing that you have to decide whether you are in fast mode or slow mode, and choose the right gear. And a lot of that is recognition that comes from experience. When you recognize that someone is really sick and they need some things done right away, and you let that part of you kick in. But if you are consciously deciding, I've got time here to think about things, let's get some more information, and making it more of a cognitive process. I don't know. I throw that up as an option anyway.
I think that's super interesting. I'm inclined to agree with you that playing to your strengths is the right thing, right? Like the cello doesn't play the part of the flute in the orchestra. I don't play musical instruments, but I assume that's true. Like you do the thing that you're really good at. But at least in medicine and often in resuscitation, both of those are important skill sets. Both the fast and the slow gear are really critical to get the job done well and correctly and to smoothly land a plane that's on fire or whatever it is, right? There's the stuff you have to do quick and the stuff that you have to really slow down and think through. And this isn't, first off, I think part of the reason we're struggling with this is we don't really have great terms for this. Like we don't really have great concepts for this. There's system one, system two thinking, fast and slow thinking, but those aren't quite really what we're talking about, right? They're just different packages of stuff. You could imagine one system that was tuned to need lower levels of certainty and to decide quicker and to make some trade-offs like that. And Zab Johnson from Wharton Neuroscience, one of the world's experts in visual processing, came on the podcast, and also somebody I'm honored to claim as a friend, came on the podcast and talked about the way the visual system handles that trade-off between rapidity and accuracy of one sort or another. So there are models for that, but even still, we don't really have the right words to describe this, like fast gear, slow gear, which is exactly how I describe it when I'm talking to my residents too. Like, you need to do fast gear first, and then you can slow down and think through things again. But I think you're getting at something here that is really important to keep pressing on. I'm open to suggestions about how to even start talking about it. I think we see bits and pieces of it, right? And for at least in our world, I think the time you see it the soonest is when a patient has a seizure, because that's just a thing that happens so frequently in the ER. That tends to be the first, I'm going to use quotes around this, the first, in quotes, crisis that a junior resident might be called upon to handle on their own without any senior backup. And you see the people that run towards the problem and set up suction and help the patient and call out orders and gather a team around them. And you see the people that sit still and think about what to do while the patient is seizing. And I think that's one of the first litmus tests for it, but it's an imperfect system and it doesn't quite capture what we really need it to capture. I don't know. What do you think about all that?
I'm just thinking that it's analogous to, we have a training 8-week thing that we do with our residents who are leading Code Blues. And one of the things that we talk about in it is the difference between having a vertical communication style and a more horizontal communication style. Debate them by asking them which one is more important in a cardiac arrest. And they come to the realization that really probably what you need at the very beginning of a cardiac arrest is a very vertical communication leadership style. And then as the team starts to gel and things come under control, then you really want to shift it and make it more horizontal. And then I challenge them to figure out where their happy place is. Are you, based on your personality, do you prefer being in a situation where you're just being vertical, just telling everybody what to do, they're doing what you tell them, and that makes you happy? Or are you more comfortable with the group coming to a consensus? And then once you know your happy place, then you know what time you need to push yourself out of your happy place. It's probably exactly the same thing with the type of decision making and the style that you're going to adopt. And just, it's a combination of recognizing what you like and where your biases are. And so knowing when you're going to need to push yourself out of your happy place. And I know that I have to, when I'm consulted on a critical care patient, and if I have to go up and see the patient and it's not a resuscitation, I know I'm not in my happy place, but that I need to push myself to just sit down, open the chart and start reading and really understand what's going on. It's not actually all that bad, but just that sort of knowing when to push yourself out of your happy place.
Oh man, I love that. Thank you for sharing that. I think that's really wonderful. Dan, we're coming to the end of our episode here. I want to give you the chance to issue a parting challenge for everybody, something you want them to do differently on Monday or on their next shift. And while you're thinking about that, I'm going to give you a little space by putting a little a disclaimer in here that we always say, which is that our job here on the Emergency Mind podcast is to figure out the best of what everybody else already knows about applying knowledge under pressure and to spread that as far and wide as possible. Our goal is not to provide medical advice, and nothing we do here is medical advice. Neither myself nor any of my guests, whether or not they're named Dan, are speaking on behalf of anybody else, just themselves. None of the places that we work for have anything to do with this. So with that rambly disclaimer, Dan, what's your challenge? What do you want people to do differently after listening to this episode?
So my challenge comes around something I was reading about a couple of weeks ago that I found to be a really interesting idea around pseudo expertise, particularly in medicine. And we all think about the 10,000 hours and this idea that we become experts in things from lots of practice. But there are, unfortunately, some areas of medicine where we really don't get feedback on the decisions that we make. And that in those situations, there is false expertise. Because if you don't get feedback on your decision making, you don't ever know whether you were making the right decisions. You just assume that you were. The article that I was reading talked about the difference between anesthetists who get a lot of very direct, true expertise because their feedback is so immediate. They're at the bedside taking care of their patient. When they make a decision, they know what happened. And then compared it to the challenges of a radiologist who will make a read, but will probably very rarely get much feedback on whether their interpretation was correct, other than during their training. And I particularly think in emergency medicine, we have both of those types of categories. And my challenge is to try to find or think of an area of your practice where you might be getting pseudo expertise. So where you are actually not getting feedback on the decisions that you make, and just brainstorm a little bit to see if there might be an opportunity to change that. So there is a guy who I really respect who I went through training with, and he wrote down the name of every patient of his that was admitted to the hospital and had a 5-day check. Like, he just checked up on them 5 days later to see what happened, see how accurate the diagnosis was, what he missed. And I think that's brilliant. And I think that's what makes people brilliant.
Amazing.
So that's my challenge.
Love it. Dan, thank you so much. Thank you for your time and attention on these matters and for digging in the work that you all are doing up there. And thank you for coming on the podcast.
Dan, thanks for having me. This was really fun. I love the way your brain works. It's really enjoyable.
Ditto, and look forward to more very soon.